I'm going to kind of start at the beginning and talk a little bit about Alzheimer's disease. So the fellow who's on the right of this slide, does anybody know who that person is? I'm sure, I mean, you guys have all, I'm sure, read a lot about this disease on the internet or in books. Has anybody seen his picture before? Sure, that's Dr. Alzheimer. And the person who is on the left of that slide is actually the patient that he wrote up describing Alzheimer's disease. Her name was Augusta D. At the time that he was writing this case presentation, that was the way that medical communications took place, was that the patient's name would be truncated in that way. And she was actually a relatively young woman who developed progressive problems with memory and thinking, and ultimately became demented by about age 43 or 44. And which is a little bit different than what we typically think of in terms of Alzheimer's disease. Usually we consider Alzheimer's disease to be a disease that affects older adults, people after age 65. And we'll talk a little bit later about why it was that this woman was developing Alzheimer's disease at such a young age, and also about how our understanding of why that was the case for her has helped us to propel our research efforts for the disease as a whole. So again, I don't want to bore you with statistics. This graph I put up here, this is something when I talk with our medical students about Alzheimer's disease and Alzheimer's disease research, I try to put it into the proper context for them, to really emphasize that this is an important disease that we need to be considering not only in terms of caring for individual patients, but also in terms of our public health policy. So this graph, which was compiled actually, so this is a slide that I borrowed from the Alzheimer's Association that looks at, well, what is the prevalence of Alzheimer's disease in the United States? In 2010, it was estimated that about 4.7 million Americans were afflicted with Alzheimer's disease, and as time goes on, you can see that, well, wow, that number sure increases dramatically. And it's estimated that by 2050, that number would nearly triple to about 14 million Americans afflicted with Alzheimer's disease. And that would be if we were not able to find more effective treatments that either delay the onset of the disease or that have an important impact on slowing down the progression of the pathology of the disease. And so, again, I was asked to come and talk to you about research, and I think it's important to understand why is research important. Well, it's important for individual patients, but it's also important that we be considering this, because if we're struggling right now to meet the care needs for 4.7 million Americans, imagine what kind of shape we would be in to try to meet the needs of 3 times that number of people in the relatively near future. One reason for this increase in the prevalence of the disease is that we are an aging country. So this first graph up here, so these are statistics that are borrowed from the National Institute on Aging. And just looking at, as a country, what do our demographics look like? You can see that as recently as 1970, that people over age 65 comprised only about 9.5% of the United States. Now, in about 2015, that number has climbed to nearly 17%, and it's projected that the number of people over age 65 will continue to grow until it stabilizes at about 21% of the United States. So, I mean, to put that into another context, that's 1 in 5 Americans will be over age 65. And that's projected to be a relatively stable number after about the year 2040. So because we're an aging society and because we increasingly recognize that dementia is not part of normal aging, this really kind of places into context why it is that we're seeing an increased importance of diseases like Alzheimer's disease. So to touch briefly on what we have learned just in the past 30 or 40 years about this disease, I want to just show you a couple of pathology slides. So pathology or histology is, when after a person has died and they've had an autopsy, when the pathologist looks at a microscopic slide of the brain, they use different stains. And what characterizes Alzheimer's disease are two findings. In the slide that's on the right, there's kind of a darker area that, it looks roughly like kind of an ovoid shape. And this is an amyloid plaque. And so an amyloid plaque, we know that in the brains of people who have Alzheimer's disease, this protein amyloid is accumulating and depositing in the brain, and it induces an inflammation or inflammatory response, and that's what we characterize as an amyloid plaque. The other slide here, you should be able to see this, roughly triangular shape. This is actually a neuron or a nerve cell that has been that's been kind of choked up with a protein called tau, and these are what are called neurofibrillary tangles. These two findings are what we use to characterize Alzheimer's disease. And that you may say, well, that's interesting and all, that you can look at a slice of a brain underneath a microscope and you can identify these findings and say, well, that's what this disease is, but how does that help us to identify a cure? So once we've identified, well, what are some of the pathology changes that cause the disease, that's the first important clue towards us being able to say, well, gee, we know that a protein called amyloid and a protein called tau are important. They're intrinsic to this disease process. So what if we were able to find treatments that stopped those proteins from accumulating in an abnormal fashion? Wouldn't it be reasonable to expect that that might slow down or stop the progression of the disease? And so one of the things that I'd like for you to leave here today with is an understanding that when we're talking about research, it's not just clinical trials of drugs that we're talking about, but also some other types of studies that lead us to identify those drugs that we're then able to test in clinical trials. So now I'm going to bore you with a little bit of science. So again, what is termed the amyloid hypothesis is simply stated that we recognize the production of amyloid, or A-beta, is important in the development or the propagation of Alzheimer's disease. As early as the beginning of the 1980s, that A-beta was isolated from blood and from spinal fluid both in people having Alzheimer's disease and in people who were a little bit older having Down syndrome, because we know that people with Down syndrome, as they age, have a strikingly increased risk for Alzheimer's disease. This graph kind of shows what our current understanding of the progression of Alzheimer's disease is. This lavender line here represents the accumulation or the increase in that A-beta protein or amyloid in the spinal fluid. So you can see that seems to be happening, relatively early on. If we consider this green arrow right here as the point where we would diagnose somebody as having Alzheimer's disease, you can see that these changes related to amyloid, which are the lavender and the red lines, are occurring many years before a person develops symptoms that would reach a threshold that we would say they have Alzheimer's disease. Likewise, this turquoise line here, that's the accumulation of those neurofibrillary tangles, or the accumulation of tau in the spinal fluid and in the brain. And so what this graph is telling us is that some of these changes that are occurring with these proteins that lead to Alzheimer's disease, that those changes are occurring perhaps 5 or 10 years or perhaps even longer before somebody develops clinically detectable symptoms. And certainly they're occurring at least a decade before we would diagnose somebody as having Alzheimer's disease. That represents a major challenge in terms of both research for early detection and for research in terms of treatment, meaning that by the time somebody is coming into the clinic with symptoms even of early Alzheimer's disease, that pathology has already gotten rolling for 5 or perhaps 10 years. And so that's telling us that, even by the time that they're coming into the clinic, we've kind of lost an opportunity to maybe have intervened even earlier. And so there are two main research themes, and so what I'm kind of setting you up for here is to introduce the idea that research in Alzheimer's disease focuses in part on identifying effective treatments for the disease, and in part figuring out how can we detect the disease earlier, perhaps even before somebody develops symptoms, so that we would say, aha, this person is having changes in their spinal fluid or changes in their brain that may lead to Alzheimer's disease in the coming years, And if we were able to institute one of these therapies at that stage, we might, in an ideal sense, we might even prevent the disease from occurring at all. I'll pause for just a minute and talk about the two existing treatments. I know that many of you may already be familiar with these, but in case you're not, I just want to at least touch on them. I told you earlier about how, we look at these slices of brain underneath the microscope, and how does that inform research? The two treatments that are currently approved by the Food and Drug Administration both grew out of those what are called clinical pathological studies. It was recognized that those amyloid plaques in the neurofibrillary tangles caused a dropout or a death of neurons that predominantly affected, or even early in the disease were affecting a part of the brain called the entorhinal cortex. And when they looked and said, well, what neurotransmitter do those brain cells use to communicate? It was a compound called acetylcholine. And so the thinking was, well, what if we were able to develop medicines that allowed acetylcholine to be more effective at transmitting or communicating from one nerve cell to another? Drugs like Aricept or Exelon or Razidine, all of those are cholinesterase inhibitors, and all of those medicines were developed in response to those observations of the changes that were going on early in the brains of people who developed Alzheimer's disease. Likewise, the drug called Namenda, it was recognized that a neurotransmitter called glutamine was a little bit overactive, and so they looked and said, well, what receptor does that act at that might be causing some problems in Alzheimer's disease? And it was this NMDA receptor. Believe me, the chemical name for that one is long enough you don't want me to say it. But anyway, this NMDA receptor was identified, again, through those pathological studies, and lo and behold, a drug was developed that was helpful at slowing down the progression of symptoms related to Alzheimer's. Towards those ends, there have been a large number of different types of treatments that have been developed, some of which have been tested already and some of which are currently under testing for Alzheimer's disease. As I stand here right now, there are over 100 different drugs that are in various stages of development, everything from what are called preclinical trials, where they're looking at a compound in a mouse model of the disease, or potentially even prior to that looking at it in a test tube and seeing, does this compound interact with amyloid, to what are called phase 1 clinical trials. So a phase 1 clinical trial is where a compound is being tested in normal, healthy controls to see, this is the first time that a compound is being tested in a human, and to see, is this a safe thing to be, looking at as a drug or not. A phase 2 clinical trial is what's called a safety trial. So there, the compound is used in people who have the disease that's being proposed to treat, but the trial is relatively smaller, meaning the trial is not large enough to definitively demonstrate whether it's effective at treating the disease or not, but the trial is the size to figure out, is it safe to use this drug in people having this disease. A phase 3 clinical trial is a much larger study where the drug has gone through its phase 1 and phase 2 clinical trials, and in the phase 3 trial, now we're looking to see, is this drug effective at treating the disease? The reason why I'm giving you a little bit of background on that FDA, what do I mean when I say a phase 1 or phase 2 or phase 3 trial, is because I will reference that information later. I'm going to talk about a few compounds. This is not going to be by any means a comprehensive overview of all of the compounds being tested in Alzheimer's disease, but I'd like to give you at least a little bit of a flavor for some of the things that are being looked at. Semigacestat was a gamma secretase inhibitor. So amyloid, the protein amyloid, is a normal constituent of our brains. It's derived from a larger or longer protein called amyloid precursor protein. And what happens is that amyloid precursor protein is produced, and these secretases cut it at different places. What happens in people who are developing Alzheimer's disease is that cleavage or that cutting is not occurring at the correct place. And so the protein is a little bit too long and a little bit too sticky, and we think that that's why it deposits as these amyloid plaques in the brain. So the thinking was, well, what if we were able to develop compounds that shifted these enzymes, these cleavage enzymes, into different places? The semigacestat ultimately proved out to be not effective. But again, there are probably multiple reasons why some of these compounds have failed, some of which have involved what patients were enrolled, meaning at the time when some of these studies were done, those biomarker things that I talked about, like with the brain scan or with the spinal fluid markers, were not as widely used or as well understood in terms of using them for enrollment criteria. Secondly, that seemingly simple graph that I put up a few minutes ago that showed, oh, well, amyloid's happening very early on, and by the time we're diagnosing even early Alzheimer's disease, probably about 80% of the amyloid has already been accumulated. That's all. A lot of that represents knowledge that's just been learned in the past 5 to 7 years. And so some of these clinical trials may have failed simply because it's not because that the drug didn't work, but they may have failed because we were enrolling patients too late in the disease for that drug to have been effective for that person. Beta secretase is another one like gamma secretase that tends to cleave a longer version of, and there are two, there's a company called AstraZeneca, which just recently merged with Lilly. That's this AZD3293, as well as Merck, are both studying compounds that are what are called beta secretase inhibitors. The idea is that if you could interrupt this cleavage process, then you may have a downstream effect on Alzheimer's disease. Both of these are currently engaged in phase 3 clinical trials. Both of them will use some of those biomarker information, both in terms of the enrollment as well as in terms of trying to study the effect that these compounds have on the disease. Again, there are innumerable monoclonal antibodies. This one was a humanized monoclonal antibody that provides some passive immunization, meaning that it tries to bind that toxic species of amyloid and just pull it out of the spinal fluid. The phase 2 clinical trial was completed this spring. They haven't yet published the results of that, but apparently their preliminary analysis was encouraging enough that they've now extended in what's called an open label extension that will go through 2016. This compound called Alzheimer was an interesting idea. What it tried to do was to actually polymerize that amyloid protein so that in a way that it could not deposit into the brain. They enrolled a phase 3 clinical trial in people having Alzheimer's disease, which ultimately did not show a benefit, and that was very disappointing. Towards that end, this AZD103 is, again, trying to look at, are there ways to stabilize that A-beta so that it's in a manner that it's not able to deposit in the brain. This one has not even yet reached a phase 1 clinical trial. It's still being looked at in mouse and in rat models of Alzheimer's disease. But again, it shows some promise. This receptor for advanced glycation end products, or the RAGE receptor. This is a receptor that resides in blood vessel walls. It is involved in the transport of that amyloid beta across the blood-brain barrier. And the idea was that possibly inhibiting this enzyme may encourage more of that A-beta to be excreted either in the urine or in the feces or something as it gets processed by the kidney. There was a phase 3 clinical trial that's looking at this RAGE inhibitor, and it is incorporating some of those PET studies and spinal fluid biomarkers into the study. Now, I mentioned another protein earlier. So I've talked a lot about now amyloid. That other protein, tau, which is involved in those neurofibrillary tangles, is also important in Alzheimer's disease. There are several reasons why tau has been a little bit more elusive of a target in Alzheimer's disease. One is that it occurs later in the disease process. The other is that tau is a protein that the pathology is occurring inside of the neuron or inside of the nerve cell. So to find a drug that targets tau, you need to find something that you can administer either as a pill or as an infusion that can then cross the blood-brain barrier and then can further cross inside of a cell to interact with its target protein. That's a lot more challenging than developing drugs that target amyloid, where it simply has to cross the blood-brain barrier but does not have to actually enter a cell. The arguments in favor of targeting tau are that the number of neurofibrillary tangles seems to correlate a little bit better with the degree of cognitive impairment seen on measures of thinking and memory. There are several compounds that have been demonstrated to kind of stabilize tau by basically blocking how many phosphorus atoms can bind to the protein. Some of them are existing drugs like lithium or valproic acid. There's a drug called cysteamine that was developed to treat an orphan disease that also can kind of stabilize this glycogen synthase kinase. There's a third drug that was specifically developed to target this GSK3 enzyme and to try to inhibit it. The phase 2 clinical trial for that has been completed, but the results have not yet been published. Likewise, there's a protein, there's another compound called TRX0237, which is a chemical derivative of something called a methylene blue. The idea is that it may block the formation of tau oligomers. It may help to dissolve some of those tau aggregations. It's involved in a phase 3 clinical trial of 200 milligrams daily. A previous version of this drug had failed to meet its primary endpoint. The thinking was that actually the drug delivery system may have been at fault in that clinical trial, meaning that the way that the vehicle that the drug was packaged in, meaning the capsule, may have actually prevented the drug from being absorbed in the amounts that it was thought to be absorbed. There's a study looking at intranasal or inhaled insulin. There's some data that would suggest that inhaled insulin may help with memory in some people having Alzheimer's disease. So there's the SNF-AD. There's kind of a funny name for a trial, but especially for an inhaled or an intranasal drug. But the SNF-AD trial is looking at inhaled insulin to see whether that may be of benefit, both in terms of memory symptoms as well as possibly in slowing the progression of the disease. And then, as I said, the goal of all of these different treatment arms is to try to eventually merge or converge with those early detection mechanisms that we talked about, and to have these two research themes, I guess, converge and potentially ultimately to prevent this disease. As I said earlier, Alzheimer's disease is a highly prevalent disease, and by having even modest impacts, in terms of delaying the onset of the disease, we can have a major impact on the number of people who are affected and who are afflicted with the disease. So with this, I'll conclude my portion of talking to you, and instead I'll be happy to open up for the floor to any questions that you may have and to try to field those. Thank you. Yes, ma'am.